Well, good evening, welcome. Welcome to the launch of the Technology Enhanced Surgical Training Report. My name's Lola, I'm a plastics trainee and I'm president of ASiT. So we've got a packed webinar this evening, so I'll move straight on to Richard Kerr, who's chair of the Future of Surgery Commission, and he's going to give us his reflections since the first report was published. Over to you.
Thanks very much, Lola, and thanks so much for inviting me to be part of your evening. Can I move on to the next slide? So the Future of Surgery report came at an interesting time, and it was really at a junction between what has been termed the fourth industrial revolution as we move into the fifth industrial revolution. Now, this is something that affects not just medicine, but affects everything, every walk of life. And it's about those changes in terms of virtual reality. It's about changes in computing, the use of mobile devices, and the beginning of human-machine interfaces. Now, interestingly, we're almost moving out of what's been termed the fourth industrial revolution. Next slide, please. To come into the fifth industrial revolution. And this is really driven by the connectivity that has happened, and this is called the Internet of Things. Now, if we look at the number of connectable devices that has changed such that we now have something like 50 billion different connectable devices, next slide, and that means that we have connectivity literally around the world. When you've got such connectivity, you can begin to utilize that for the benefit and advancement in all these various different areas. Next slide, please. And that brings you into the concept of the fifth industrial revolution. Now, we're kind of already utilizing this in medicine. This was a report published a couple of years ago where surgery was carried out 3,000 miles away from the surgeon. Next slide. And that was achieved using, next slide, 5G technology. Now, we've got to have that sort of stable platform if we're going to really reap benefits from this. Next slide, please. So the fifth industrial revolution, some would say that it's the AI revolution, but we think that's already happening. Some would say it's to do with quantum computing, but actually we've already got that. I think that a more broad view will be this is a time when humans and machines actually begin to work together in the workplace. There is another view on what the fifth industrial revolution is about, next slide, which I think is really important, and that is that this is a time for us to begin to achieve work-life balance and the recognition of how important that is in terms of our family life and in terms of our future health. Next slide. So the Commission was born out of this era of change. Next slide. And we put together a group to actually look at this and try to see what surgery is going to look like over the next 5 and up to 20 years and to try to bring these changes together. Next slide. So what did we find? Well, I'm going to demonstrate this by looking at cataract surgery, which is not my field. I'm a neurosurgeon by training, but cataracts are the commonest surgical procedure that's undertaken in this country if you leave dental work out of it. So in the next 5 years, obviously demand's going to increase as we would expect with population demographics. Artificial intelligence is beginning to be used to help us in terms of the diagnosis of those with cataracts. We're also moving into a time of smart lenses when we get adaptable lenses as opposed to the static lenses that have been put in. We're going to use artificial augmented reality platforms for training. And then if we fast forward another 10 years, demand's going to increase. By that time, AI will be routine in terms of diagnosis and probably the surgery done by robot-assisted techniques. I think we will be using remote surgery by that stage. But what's really amazing is the concept that with stem cell therapy, we might even get to a point of lens replacement as opposed to simply putting in a new lens, which is what we're doing at the moment. So next slide. If you just look at cataract surgery, it kind of embraces everything that we identified that was important in the future of surgery. So genomics and big data, the use of augmented reality, virtual reality with simulation as well, minimally invasive surgery, particularly with robot-assisted surgery, and some specialized interventions. Next slide. Now, if we are going to achieve all of that, those are the specialized interventions. Next slide. So if we are going to achieve this, it's going to be delivered through a surgical team. Now, we already work in teams, but I think the diversity of the team will increase, particularly as complex and more specialized interventions come on board. And we're going to need engineers and geneticists, as well as the surgical team that we expect right now. Next slide, please. So the surgeon, I think, will change. Surgical careers are going to become less distinct and more flexible. Surgeons are going to have to understand the language, particularly the genomics language, that will be so important. And there may be a greater role for non-surgeons. Now, I appreciate that's something that we would want to debate, but I think it needs to be on the table to consider. Next slide, please. The benefits for patients: earlier detection of disease has to be the biggest benefit, but also personalization of treatment. And I think if we can achieve those two things, then it will mean that we are able to identify disease at an earlier time point, and we can move away from organ removing surgery towards organ sparing surgery. But we can also tailor our treatment specifically to individuals, thinking about the responsiveness of their particular condition, how well they'll do in surgery, even the chances of them developing complications are all potentially predictable according to their genetic makeup. Next slide, please. So this concept of change will affect the entirety of the patient's journey. And again, we need to be moving away from treatment and follow-up to health disease prevention and trying to improve the health of patients generally with disease prediction and early detection and diagnosis. So I think it's changing where we enter into this cycle more and more will help us in terms of the way we improve outcomes for patients. Next slide, please. At the same time as the Future of Surgery report was published, you will know that the Topol report was also published. Next slide. And this was a piece of work that was commissioned by the then Secretary of State for Health to look at preparing the healthcare workforce for the digital future. Next slide. The conclusions that came from the Topol report were based really around these concepts, and particularly when we talk about education and training. So looking at the surgical curriculum and how that would need to change and develop more agility for change. The knowledge of IT, engineering, genomics, so a much broader spectrum of knowledge. Acceptance of training and career flexibility, which I think will be a big step forward and a very positive one. The importance of mentoring and proctoring, but this is going to affect the whole workforce, not just the surgical workforce, the medical workforce, the nursing workforce, and so on. And with that, there needs to be time allocated for training within all of these different work spheres. The last point is increasing the diversity of entry into med school when it comes to training in medicine. Next slide, please. So the college has also picked up from the Future of Surgery report, and it has been looking at developing many changes throughout the work of the college, whether it be teaching and training, whether it be standards and how we look at new devices and new techniques, looking at patterns of care and that drive towards early preventative organ sparing surgery. We also we need to pick up the issue of sustainability and green theatres, which is not in the report, and that was an omission. And then obviously behind all this, we need to maintain our drive for research to absolutely be sure that what we're doing and the changes that we're suggesting will be effective as we go forward. Next slide, please. If we look just at training, it's about what does the surgeon and surgical team of the future look like, and how can the college change to deliver the teaching and training that will help people move to what's required in 20 years' time. And there is a program that's ongoing at the college for that. Next slide. I don't want to go through this in detail, but there's a whole load of e-learning projects that we've put together, an expert advisory network, and working with HEE to try to build that diversity into the training. Next slide, please. In terms of minimally invasive surgery, this is another important area, and we have put together a robotics group, which is called RADAR. But there's various themes within RADAR, including working with the commissioners and HEE about how we implement minimally invasive surgery, particularly robot-assisted surgery, and how we develop those training platforms with the robotics companies. And we've been in discussion with all of those companies about that. We've also been working with the HES data set to look at robotic procedures and try to understand how many procedures are truly done and where and why are they being done there and not in other centres. And then behind that, there is a whole series of research projects that are ongoing to look at the role and the value of robot-assisted surgery, and particularly the teaching and training of that. Next slide. Then came COVID, and of course COVID has had a huge impact on this. So why do I mention it? Well, because I think the impact of COVID has been fascinating. Clearly it's had an enormous impact on outpatients, waiting list, disease progression therefore, but it's also had an enormous impact on teaching and training, and I'm sure we'll touch on more of that this evening. But it has driven change. It's driven change in connectivity, so webinars like this. Pre-COVID, the majority of meetings we went to would have been face-to-face, and yet now this is considered a relative norm. So COVID has driven change. It has allowed us to look and adopt new teaching methods, but I think there's much more work to be done on that in terms of how we can use mixed and virtual reality and simulation platforms. But it's also highlighted that sustainability issue with a mountain of single-use plastics that we now have to deal with. Next slide. So finally, therefore, the areas that the Future of Surgery Commission identified, there they are: genomics and big data, imaging, simulation, and augmented and virtual reality, minimally invasive surgery, and then some specialized interventions, particularly the human-machine interfaces, but stem cells. But already we're beginning to see some of those changes. And I think that in some ways, COVID has helped drive those forward. But this initiative, in terms of the Teaching Hard Surgical Program, I think that really will drive very much more how we deal with the teaching and training to the very best advantage of those participating in it, but ultimately to the patients at the end of the day. Thank you very much.
Thank you very much. Some very wise words there. So I think in the interest of time, we'll save the questions for the end. So next up is Mr. Josh Burke, who's a general surgical trainee. He's the chair of the Commission of Technology Enhanced Surgical Training Report, and he's also the immediate past president of ASiT. Thanks, Josh.
Thanks for the introduction, Lola. We're delighted to be announcing the commission of the report this evening, and thank you to Mr. Kerr for perfectly setting the scene. Next slide, please. So I guess this entire concept is borne out by the sensible assumption and motivation, really, that the more improvements we can make to training, the better care we can deliver for our patients. Next slide. But what we've seen over the last decade, really, as the original Future of Surgery report predicted, was huge investment and growth in digital health. And I'm sure many of the UK trainees on the call will not need reminding of the current state of UK surgical training following the pandemic. Next slide. And through discussion with ASiT, BOTA and the trainee specialty associations, there was some concern that surgical training was being a little bit left behind, with huge potential of improvement. And perhaps what we started to see was a repeat of the digitalisation of the NHS, with many areas working without collaboration, with investment separately into technological solutions, without really an evidence base before rigorously defining the unmet need from, I guess, the end user us as surgical trainees. And so we worked with the English College Radar Committee to set up the Digital Surgery and Robotics Trainee Group, which has representatives from all trainee committees and importantly is intercollegiate. Next slide, please. What became clear through discussion with the huge success and impact of the original report was that there was much more to learn in terms of addressing deficiencies in surgical training and to push forward and think and make training better through technology. And so we approached the college to support the Technology Enhanced Surgical Training Report, which we launched this evening. And this has 4 main aims really, which we hope to deliver over 3 phases. Next slide, please. The first one was to define the unmet need. We're really grateful to Health Education England, who have allowed us to analyse their surgical solutions survey results and the results from their specialty training risk reporting tool, which they run annually over the last 4 months. Next slide, please. And what this did was it allowed us to complete 2 national consensus hackathons. The first ran earlier on this year and was open to any trainee with an interest, and the second is being delivered by Lola next week with trainee representatives from all specialty associations across the country. As part of that process, using the analysis that we've done, we asked trainees to rank their unmet needs in terms of urgency and importance to help guide the second phase of the project. Next slide, please. We're then able to use this information and map the unmet needs and early suggestions of possible solutions to 2 streams. The first, the training opportunities within the patient journey, so diagnostic, surgical intervention, preoperative and postoperative care, and where the training opportunities are in those areas. And the second, the trainee journey, from recruitment all the way through to CCT. And these unmet needs will be the basis of evidence submission, which is completely open to anyone interested in contributing. Trainees, trainers, industry, patients, and Gina Hardy will explain how to get involved a little bit later on. In addition to this, we have the support of Sally Williams, an experienced health services researcher, who will be performing case example interviews of digital solutions from industry, covering the spectrum of unmet needs that have been identified. We're grateful for the college's support and Sally's time in doing this. Next slide, please. As part of this project, we brought together all the stakeholders we can, and we have had early discussions really with those necessary in how to achieve this final phase, and that is to develop a rapid assessment process to appropriately assess training intervention. Flipping the paradigm really of starting with the solution, a common mistake made in tech innovation, which we can't really afford to make in the current training climate. Next slide. And underrunning everything we do, which should be the case not only with regards to surgical training, will be 3 key pillars: equality and diversity, sustainability, as Mr. Kirst touched on, and this balance of well-being and mentorship, which we need to see more of, certainly in our surgical training. Next slide, please. Oh, sorry, missed a slide. So the commissioning group has been assembled to reflect what I've just described, and a huge thank you for their hard work to date and the commitment that will be required to get this over the line. This is led by trainees for trainees, independent but working with key players in the digital health industry. A few final thoughts. 3 words really that keep popping up from what we've learned so far. If trainees don't know what's out there, they can't really assess it, they can't critique it, and they can't make their own minds up about what they're processing and problems they experience in training, and at times predict as future independent practitioners can't really be connected to potential solutions if there isn't an easy way of getting hold of that information. Agreement. We practice evidence-based medicine and training should be the same. Changes to training should be rigorously assessed and evidence-based, and there needs to be agreement from both trainees and trainers as to what works. And then finally, access. If trainees don't have access to the new training interventions, positive change will never be adopted. And we hope that the report will kickstart this process. Next slide, please. So that's just our commissioning group, which we're incredibly grateful for. And next slide, please. So for the rest of the webinar, I've got 2 great talks, one on artificial intelligence and one on machine learning, which converge really nicely into what's probably the most well-trodden path in terms of potential solutions, but with yet no current adoption, and that is virtual logbooks and telementoring. We'll then finish off with an overview of how you can get involved and some questions if we have time. So it's a pleasure to introduce Manish George, who's the chair of the Trainee Association of Otolaryngology, so AOT. He's currently completing a PhD in the subject area of his talk. Manish, over to you.
Hi everyone. So yeah, I'm Manny. So to avoid overlap, I'll be focusing really on AI in general, and then Tamara, who's speaking after me, will give you some more specifics about artificial intelligence in surgical training, but with a specific focus on machine learning. So I'll talk about AI. I'm talking about some components of AI, natural language programming, machine learning algorithms, and then briefly on supervised versus unsupervised learning. We'll chat again briefly about deep learning and then touch on AI in surgical training. It's really going to be a whirlwind crash course. So excuse me if I skirt over some things. Next slide, please. So AI's roots are found across several fields, from psychology, linguistics, statistics, and robotics. Next slide. But really, we're focused on two main areas when we talk about AI. The first is general artificial intelligence, which is currently confined to the domains of science fiction. Strong AI, or artificial general intelligence, is AI that can perform any intellectual task that a human being can. And you see this in the sci-fi movies, Her, Ex Machina, or Machina, Blade Runner, The Terminator. Next slide. But the thing that we're more focused on is narrow intelligence, or weak AI, and rapid advances in computing, data storage, technology over the last 5 decades has brought this AI, narrow AI, from the realms of science fiction to a reality. So narrow AI is really focused on specific tasks with predetermined and a predefined range to assist humans. Next slide. So really, it allows computer systems to perform these specific tasks that normally require human brain processing or human level function, and sometimes to supersede them. So this may be things such as visual perception, object and word recognition, or even complex associations in data. Next slide. So this Venn diagram gives you a very brief overview of artificial intelligence and all its subcomponents and how they overlap and interact. Specifically, I guess, with reference to the research that's taking place in medicine and surgery. Next slide. So natural language processing, again, perhaps not the most commonly remembered area when we hear about all the headline research, but it is a very important area, and it's predominantly focused on the evaluation of text or spoken language to make information accessible to a computer algorithm or computer program. So really, the goal of natural language processing is to allow people to interact with computers in plain language. So unlike, let's say, a dictation program that many of us have used, a natural language program, AI Virtual Scribe, could automatically integrate clinical information from other sources, previous notes that are relevant, pertinent radiology, lab reports, just like a good SHO or registrar would do on a ward round. So potentially, one impact of this, it may save trainees a huge amount of administrative time, and it can also potentially make the learning process easier when we as trainees are able to interact with computers, robots, stack systems via speech. Next slide. So machine learning, this is perhaps the most well-trodden and the area that's, I guess, the lowest hanging fruit when we think about artificial intelligence. It's certainly the largest area of research when it comes to surgery and medicine. So next slide. So MLAs, or machine learning algorithms, enable computers to learn from data and experiences and essentially act without specifically being programmed. So if you think about a computer program, let's say your Outlook, you click a button, the software is hard coded, that click will send an email. Now, that's not the way that these MLAs work. They work, as I've said, without specifically being programmed. So you don't explicitly tell the computer how to achieve its goals. And if you don't do that, it may find patterns that are actually imperceptible to humans in this data. So it's a very powerful tool for solving complex problems, and it has huge potential. Next slide. There are two main areas, supervised machine learning and unsupervised machine learning. And again, we'll touch on them briefly. There's a third area called reinforcement learning that is tied in perhaps more with autonomous robotics, but we won't be touching on that today. Supervised machine learning, essentially you've got a data set, human beings label that data set, the algorithm learns from the labeling, understands the data and develops an inferred function which will hopefully accurately represent the data. And this inferred function that it's learnt can potentially be used on new data, unseen data, to label it. So that's the kind of stuff that you see, as I've mentioned before, in the big headlines, AI diagnoses retinopathy or diagnoses cancer on mammograms or cancer on skin photography. That's all done via supervised machine learning. Next slide. So unsupervised machine learning, I won't dwell on this too long because perhaps it's a bit less intuitive, and in general it's used less than the supervised. Supervised machine learning is much more popular and certainly is the lowest hanging fruit. But algorithm will look at a large data set and without any labels cluster the data into different groups or clusters that it feels have matching intrinsic features. And so the human may look at these clusters and decide, well, okay, that group represents this type of patient, that group represents that type of patient, or this type of complication or that type of complication, and it labels these clusters after the computer has clustered them. And the program may use this function to then cluster new data into these groups. Again, slightly less intuitive and not used as often, but has an important role. Next slide. So how do we create a machine learning algorithm? Very briefly, you take a large data set, you process the data, and then you split that data up. By convention, 70, 80, 90% large amount is training data, which you apply this machine learning algorithm that we discussed through multiple iterations, so it learns multiple over a course of multiple cycles to develop an accurate map or an accurate function. And then you test it on the data you've put aside, maybe 20%, and see how well it performs in that data. And the really good algorithms, the really good studies validate this on an external data set, so from a different hospital or from a different country sometimes, to really assess how effective and how global or how broad your algorithm is, i.e. it's not just good at looking at your own specific data that you've trained it on. Next slide. So neural networks and deep learning, perhaps the sexiest and most exciting area of AI. Next slide. So this is a diagram representing the programming that goes into developing a neural network. You have data that travels through these nodes. These nodes represent neurons, and these nodes are essentially just programming, just language, computer language programming, stuff that most of us medics and surgeons aren't familiar with. So the data passes through this input layer of series of neurons with the data that you're playing with, you're using, you're incorporating and analyzing, and it passes through multiple layers, traversing all these nodes, which each connection acts like a synapse in the brain and transmits this data from node to node. Now it passes through multiple hidden layers, and if there are several hidden layers, that's what's known as deep learning. So the process will undergo multiple iterations, and these connections are pruned to best associate the inputs to an expected outcome. So the networks formed in these hidden layers or throughout the network are so complex sometimes that really it's not accessible nor comprehensible to us as humans. So it would be like trying to interpret a thought process by looking at someone's brain tissue. It's so complicated and so difficult to understand that it poses ethical questions as to the explainability of these algorithms and who is ultimately accountable for the outcomes. Next slide. So final two slides. AI in surgical training. So how may it be applicable? In general, as I mentioned earlier, the automation of routine, time-intensive admin may save trainees a lot of wasted time, especially via the natural language programming. Potentially, with large data sets trained on previous registrars, algorithms may be able to identify trainees at risk based on WBAs, when the WBAs have been done, what kind of scores they're getting, and also incorporating a whole host of new data that I'm sure Tamara will touch on and has been discussed earlier, operative information, robotic-based information, videos of surgical trainees. It may also be able to identify generic areas of improvement that a trainee may have, or identify areas they need to focus on and improve gaps in knowledge. Next slide. But specifically, algorithms may predict and assess performance through the interpretation of simulation data, video recordings looking at pace, efficiency, economy of movement, or intraoperative complications, eye tracking, robotics. Again, training this data or using this data and formulating an algorithm that can direct training through better intraoperative instruction and labeling and augmented reality has huge potential. And also preventing of complications. So what do I mean by a hybrid situation? You have simulation where the patient is completely safe, and you have full-blown operations on patients who are at risk of any complications from a trainee or any surgeon. Now, a hybrid situation may have technology that has got an AI foundation that can minimize complications by not allowing learning or junior trainees from accidentally ligating the wrong vessel or damaging a nerve when it's incorporated to powered devices or the robot. Again, some of this technology may be in the more distant future, and some of it is certainly around the corner. It's all an extremely exciting area. Next slide. So this is what we've covered, really a whirlwind course. Again, I'm sorry for being brief in some of these areas, but there's a huge amount you can gain online by reading. Next slide. In summary, it's an area of huge potential to revolutionize medicine in general, but of course, surgical training. And Tamara will, I'm sure, give you a lot more information with some specific examples in machine learning. Thank you.
Thank you very much, Manny. That was a whirlwind tour, but I learned a lot. So next up, we've got Tamara, who is an HPB registrar in London, working at the Royal Marsden. She's completed a robotic HPB fellowship and is a robotic representative for the RU group on the radar group. So over to you. Thank you.
Hi, thank you. As Lola said, my name's Tamara and I'm the RU group HPB and upper GI representative for the radar trainee group. Manny has eloquently explained what artificial intelligence and its subset machine learning is, and I will talk through some of the early machine learning research conducted in surgery. For the Future of Surgery report, we would welcome any editorials on this research or new audits or research that aren't yet published or in the process of being published to incorporate into our final report. We'll briefly look at papers which have used machine learning for surgical phase recognition, gestures and error recognition, and anatomical landmark recognition. And finally, a few future directions, the way I see it. Next slide, please. Surgical phase recognition is the foundation of machine learning in surgery so far. Every operation that's done can be divided into distinct phases or steps. In brief, the way this is done is operative videos are analysed and annotated by experienced surgeons. The annotated frames are used to train and test neural networks with labelled supervised learning, as Manny explained, in order to develop models which can then be used to assign the stages of an operative video to the operative phase. This may benefit the trainee surgeon to learn operative steps more quickly. It could alert surgeons when approaching possible complications or areas of operations where complications may happen. It can support decision making and allow for procedure annotation and indexing to enhance reflective practice and reduce the surgical learning curve, as well as providing comprehensive educational tools for training from the recorded videos step by step. The majority of work has been on laparoscopic cholecystectomies, mainly because 95% of these operations are done with minimally invasive techniques, so there is a wide availability of videos and internationally video data sets. Others have also created models for phase recognition during sleeve gastrectomy, sigmoidectomy, and endoscopic myotomy, but it's definitely still in the very early stages in surgery. Next slide, please. This diagram explains how the machine learning models are created in brief. The data on the left of the diagram, i.e. video features, instrument use, and motion metrics, are used to and annotated by experts. The experts correctly identify the phase of the operation from the data, and this is introduced as labeled training data to the computer system. An artificial intelligence model is then created, and further data, the testing data, is input into this model to test how good the model is. The automated phase recognition is then compared to the expert's annotated data. Next slide, please. This systematic review identified 30 studies that had created models to identify the stages of laparoscopic cholecystectomy, varying from splitting the operation into 5 to 20 phases. All of these included callous triangle dissection, clipping and cutting of the cystic duct and artery, gallbladder dissection from the liver bed, and gallbladder removal. The models that each of these papers were able to create could predict the operative phase when going through testing data of videos with an accuracy of 67 to 97%. Next slide, please. Research currently being conducted at Imperial College in conjunction with touch surgery shows how this can be used in practice. During an operation, as pictured here, in this case a sleeve gastrectomy, the screens you can see are on view for the surgeons, the scrub team, and the anaesthetists. These identify which phase of the operation is being completed, the average time taken for that phase, what the next phase of this operation will be, and which instruments will be required for the next stage, thus improving theatre efficiency, estimating surgery duration in real time, and aiding decision-making for the trainee surgeon. Next picture, please. The surgeon can then easily upload the operation to their individual video database on their smartphone with the Touch Surgery app, and this will analyse the time taken for each operative phase and compare this to their previous operations, enabling objective reflective feedback. Next slide, please. There has also been work aiming to identify surgical gestures and errors in order to analyse surgeon proficiency. Next slide, please. So using robotic surgery footage, these authors, Lee et al., developed deep learning algorithms to recognise the tips of the surgical instruments, so they knew which instruments were being used during the operation, and they were able to track their trajectory and motion. From this data, they were able to develop a surgical skill prediction model which compared well with an accuracy of 83% to experts who had scored the surgeons with the traditional OSATs and gears methods. This has huge implications for future surgical training, as the ability of automated proficiency testing from either simulated or recorded videos may determine when a trainee is allowed to operate on patients, or when they're able to move to more complex or technically difficult operative steps. Next slide, please. And there's another paper where Luongo et al. Analysed 2,395 videos of robotic urological procedures. They use this as a training data to develop their artificial models or computer models, and then they use 511 videos as testing data. By analysing the right and left hand movements of the surgeons on the robot, as seen in the diagram, they developed an automated classification of suturing gestures. So they were able to tell from what movement your right hand was doing, or the motion metrics that were recorded, and the motion metrics recorded of your left hand and combined manoeuvres, whether the surgeon was needle positioning, needle driving, or suture cinching. The deep learning algorithm they created was able to classify these gestures with an area under the curve of 0.87 and 0.88. The deep learning model was also able to stratify participants into 3 skills levels, novice, intermediate, and expert, and estimating their scores on the OSAT scale with a precision of 0.67 to 0.85. Again, demonstrating the potential to utilize these deep learning models from video analytics and motion metrics towards automated surgical skill assessment. Next slide, please. And sort of a step up from that is whether can machine learning be used to actually identify surgical anatomy. And this has been a much more difficult step of machine learning compared to its more thorough investigations in radiology. When you have a surgical video, it's a more difficult task. There's lots of camera movement and motion, there's smoke, artifact, and all the structures that you see are covered in soft tissues, etc., etc. Next slide, please. However, this I think is a fantastic paper which was published last year, where the surgeons trained a deep learning model using 2,627 frames from 290 laparoscopic cholecystectomy videos. And expert surgeons annotated each of these frames to show a go zone, meaning the area within the hepatocystic triangle which you can dissect, and a no-go zone, i.e. the hepaticoduodenal ligament, liver hilum, and inferior structures where there's a higher risk of creating a bile duct injury by dissecting in that area. And from the model that they created, they were able to identify these go and no-go zones with an accuracy of 0.94 and 0.95. You can see on the diagram on the right 3 examples from the individual frames taken from the videos. So the first picture on the first row shows the frames from the laparoscopic cholecystectomy videos that we used. And the second row shows the model's prediction of the go zone and the no-go zone areas. Taking this one step further, the model was able to produce a dynamic overlay of the zones onto video footage, which I will show on the next slide. Next slide, please. And if you could play the video. You can see from watching this video how this may be able to aid the trainee surgeon in the future with real-time augmented reality overlay of safe and unsafe dissection zones whilst operating. This will reduce the surgical learning curve and improve patient safety. Next slide, please. With an increase in minimally invasive surgery, particularly with robotic surgery, we're going to have access to a huge number of videos and performance metrics data, which needs to be recorded and needs to be collected. This will increase the ability of machine learning research in surgery across specialties. Simulation continues to improve, and specifically with the Da Vinci training modules now on any Da Vinci simulating machine, there's specific operative simulation modules which go through each operation step by step. So there'll be a lot more self-directed training. Automated surgical phase recognition may reduce intraoperative training, increase theatre efficiency, and reduce the surgical learning curve. There may be a requirement in the future to achieve high automated simulation scores prior to operating. And also for operative videos, they may have automated assessments and proficiency testing before you can move further with your operative training. Real-time augmented reality may be used to display anatomy and danger zones, improving both training and patient safety. And as a final thought, I think we should strongly encourage the development of partnerships over the next few years between surgeon scientists and computer scientists to enable machine learning to develop as it should over the next 5 to 10 years. Thank you.
Thank you so much, Tamara. That's really cool about the machine learning. And kind of leading on from that, I'd like to introduce Mr. Will Bolton, who is the ASiT Innovation Lead, who's about to start his ACF in neurosurgery, who's going to talk to us about virtual logbooks.
Thanks very much, Lola, and thanks to the chairs for inviting me and for putting together this webinar. And congratulations to Josh Burke and his team for the amazing technology enhanced surgical training report that we are launching today. It's really, really exciting. So I won't take up the full 10 minutes, but really I just wanted to sort of pull together some of the technologies and themes that have been touched on by my colleagues, Tamara and Manny, just about as an example of how we could use these to improve surgical training, and that is this concept of virtual logbooks. And I think I want to stress that the technology enhanced surgical training report is much bigger than this, and this is just one of the potential examples of areas that we want to part of the scope and areas that we want to work in. So I think it's really important to start with the unmet need when thinking about any kind of change that you want to affect, especially with technology and innovation. And this paper that ASiT published at the end of last year was the largest paper that looked at workplace assessments. And it sort of discussed some of the challenges and some of the pros and cons of the current model of logbooks, and it's often challenged as a truly accurate method for demonstrating competency. And as we're moving from a time-based progression to a competency-based progression, it's potentially not fit for purpose. And as we've been talking about these novel technologies coming through from AI and machine learning, and with extra techniques that we can use, such as robotics, it might be an excellent opportunity to sort of leverage, as these technologies are coming in, how they might impact how we collect our training evidence. And a digital method of reviewing operative competency, both live in real time, but also retrospectively from multiple sources, might align with the new MCR report, which is coming into effect this year. Please feel free to read the paper for the full results, but it looked at 906 trainees from a pan-specialty, pan-grade sample in a reasonable cohort of trainees, and it highlighted, among other things, that 41% are aware of unobserved sign-offs. So there's a potential there for the video logbooks, the virtual logbooks here, to address that unmet need. Next slide, please. I think it's really important to also focus on the potential of the technology here. We've heard that robotics and other laparoscopic techniques are hugely data rich, and that gives us an enormous potential to gather a whole host of meaningful outcomes and meaningful metrics that the trainee and the trainer can use, but also healthcare systems and technology developers might also be able to use, for example. And it represents a convergence of technology as well, with AI integration and robotics, for example, being an excellent use case for this. There might also be scope for you to log simulated training cases. So as simulators get more and more advanced, as I mentioned, particularly with robotics, aligning with what happens in other industries, the aviation example is often used, but where you have to log a certain number of cases simulated in your logbook to demonstrate competency and as part of the whole process, which I think is a really exciting opportunity, particularly for junior trainees and trainees as they move on to more complex procedures as they progress. And finally, this concept would potentially couple with the concept of theatre black boxes, which it's not just necessarily the surgeon and their skill and exactly what they're doing with their hands at that moment in time that affects outcomes, as we know from human factor science. It's how the team is working and how lots of other factors and processes are in play during the operation in the theatre, and indeed the wider system that the patient is in. Next slide, please. And we're not unaware of the huge culture shift that I think is going to be needed to persuade policymakers and trainees and everyone involved in this to consider adopting this. And I think it's about informed augmentation of how we collect our training evidence, rather than a replacement of what we're doing so far. It's about how we use these technologies to augment, and we have to make sure that it's for the benefit of the trainee, trainer, system, and patient. Of course, we have to make sure that we include insights from all these different groups, and these are just some of the issues that I suspect will be on the top of people's minds, and there'll be many more. And I think the key is that engaging in conversation with these concepts early is what's absolutely critical to improve the adoption of concepts and technologies like this. For example, fear of litigation. So, if I record a video and something goes wrong, can a prosecuting lawyer, access that and use it to prosecute and challenge me or the system or the trust? There's uncertainty or sort of maybe potentially a lack of confidence around consent, what consent's needed for the patient, for the trainee, and for the other members of staff that might be captured by the video, for example, because this of course could be used for open surgery as well with other methods of video capture. But then on the plus side, a culture shift that fosters open practice and then learning and shared best practice is I think most people would agree is a good thing. And I think from a trainee's point of view, it's about getting data-driven, personalized feedback, which I think is really, really exciting, rather than kind of rather binary, yes, no, or, kind of anecdotal feedback. You can actually get data-driven, informed, personalized feedback, which I find really exciting. Next slide, please. I think this goes back to what Josh was saying in his opening slides. What we find when we are trying to introduce change or affect change is the kind of awareness, agreement, access concept, which is I think particularly powerful. And we're trying very much to make sure we align our activities and thinking to these sort of three main pillars. And the awareness is part of the aim of this report is to generate awareness and discussion. And through this, we'll interact with multiple stakeholders, including potential industry solutions and industry partners. And we might also be able to be involved in some usability testing and platform design for potential video solutions. Generating agreement is absolutely essential, and ensuring that there's pan-grade, pan-specialty trainee and trainer collaboration is absolutely key with all the various stakeholders, as I've already mentioned. And we've got a series of targeted, accelerated Delphi consensus processes to ensure that we address the key issues, we identify and continue to address the key issues that might affect everyone involved. And we've already ran, as Josh mentioned, a couple of consensus hackathons, which is a novel methodology that we're sort of developing and will continue to utilize. And then finally, in the access, it's about feasibility studies. It's to actually get feedback to the providers who are providing potential solutions, and we're in consultation with a range of potential options from industry and indeed from academia. And the idea, I guess, would be to perform and inform and perform comparative evaluations between different options to ensure sustainable implementation of a solution. And indeed, generating the evidence to inform adoption is absolutely essential. Next slide, please. I think that's everything. And yeah, so thank you very much for your time. And yeah, we'll cover any comments and questions.
Thank you very much, Will. It's pretty exciting. So finally, I'll hand over to Dina Haji, who's a post-CCT fellow in robotics and advanced pelvic oncology in Bordeaux. She's an exec member of the RCS Radar Group and former president of Duke Club.
Great, thanks Lola, and thank you Josh for inviting me. I suppose I'm right at the end of my training and starting that transformation between trainees and becoming a trainer. And I think it's important to acknowledge that TEST, or Technology Enhanced Surgical Training Report, is here to be visionary. It's here to think about how we change and improve surgical training in the future to make it accessible and equitable for all, to reduce variation in the way surgical training is delivered across the country, and to standardise it. It's to enable objective assessment metrics, as you've already heard from Will, that it's about creating data-driven, personalised feedback and really lean towards a proficiency-based curriculum to make you a better surgeon, to enable better clinical outcomes and better patient-reported outcomes. And if you're listening to this, and if you've been listening to this whole webinar, I mean, I don't really need to convince you why you should get involved. My predecessors, who've all eloquently highlighted various aspects of tests, should have convinced you just by the merit of their talks. But what I want to say to you all is that technology enhanced surgical training is here for everyone, from medical students, junior trainees, course surgical trainees, higher trainees, and consultant colleagues. And there are many reasons that you should all get involved, because we want to create an inclusive community of technology enhanced, digitally connected surgeons for the future. So to the medical students and the junior trainees listening to this, I say to you that you should join us and really shape the surgical training that is suitable to your needs as a 21st century digitally connected, digitally driven trainee. To those higher surgical trainees, to the ST3s, all the way up to your post-CCT fellows, I think that what we should be doing, and I include myself in this, is really looking to create the training program we wished we trained in, and to create the training area that we want to deliver training in. We are the trainers of the future, and this is our opportunity to have a conversation about how we deliver surgical training in the future. And to my consultant colleagues, I say be part of the change and embrace new solutions in delivering surgical training to improve clinical and patient outcomes. Next slide, please. So how do you get involved? Well, it's all very digital. You go onto Google, if you type in the Future of Surgery report or Future of Surgery, you'll find our website. And it's great to see that actually we've co-hosted on the Future of Surgery report to really show that we are connected with, and the next step of the Future of Surgery. Training is the future of surgery. Scroll right down to the bottom and you'll see that we've got our 3 key areas: defining the unmet need, current evidence and case synthesis, and that it goes across the patient pathway and it goes across the training pathway. And then you've got our submission of interest. Click onto that and it's very simple. We ask you for some basic demographics, the area that you're interested in and the type of submission that you would like to be a part of. Now, if there's something that we've missed, there is another category. We are open to receiving all sorts of submissions. Nothing is off the table. Everything is there for us to consider. We have a whole host of different types of areas that you can get involved with. That's from pre-operative care, digital technology, wearables, post-operative care, training pathways, robotics, virtual logbooks, etc. And then all you do is decide what sort of submission you'd like to make, what you'd like to call it, what its aims might be, and what sort of methods you might think that are appropriate to deliver your aims. That will then get uploaded centrally, and the radar team will have a look at that, and the radar trainees team will have a look at that, and we'll try and map you and connect you with like-minded individuals to deliver key aspects of the report. Like I said, no one is too junior or too senior to get involved, and we really want to make this an inclusive and diverse and digitally rich community. And so that's all I'm going to say. I'm going to say that this is your opportunity to change training. As we've all experienced in the last 12 months, training has changed beyond belief. COVID has had an impact on us that we had never considered before. And now it's our opportunity to think about how we change training in the post-COVID era to deliver training that is suitable for us as 21st century surgeons and digitally connected trainees. Many thanks.
Thank you very much, Dina. I mean, a fantastic array of talks. I think everyone should be really inspired by this. There are actually some really good questions in the chat, but unfortunately we don't have time. We kind of run over. So advise if anyone could just go to the ASiT Twitter @ASiTofficial, and we can continue the chat there. But thank you so much to everyone on our panel. And I think the message going out to everyone is, if you are going to be involved in training or surgery in any way, shape or form, you need to get involved. So Dina showed you how to do it. Go to the website and get involved. So again, thank you very much to our panel, and thank you very much to everyone for joining us. So have a good evening.
Thank you. Thanks, Lola.
Bye. Thank you.